Hello and welcome to yet another one of our Wilmington Healthcare Coffee Conversations. We haven't done one for a while, so this is going to be the first in a new batch, and the first one that we're going to do covers the tricky and complicated subject of oncology. And with me to talk about that today is Sarah Shields, our healthcare consultant, sitting on our consultancy team. And we've got quite a lot to cover here, Sarah, haven't we?
Yeah.
So don't know where this is going to go, but oncology is an area of interest for you, and we're going to just explore a few things that we've come across that we think are going to be of interest. And I think one of the first things to say, isn't it, that it's not one thing. Oncology is lots of different specialties with lots of different customer groups and funding routes and ways of delivering the service and all that.
Yeah.
So
Yeah,
you agree, you've got to sort of break it down and look at the individual, say, tumour type that you're interested in, and work out what's going on with that rather than looking at it in the round.
yes, absolutely. And I think it's, just the fact that it is quite, not necessarily disjointed, but it's complicated.
Yeah.
It's a very complicated picture
Yeah,
of
yeah.
how you get diagnosed, how you get treated, where you get treated,
Yeah.
what diagnostics, what medicines.
Yeah,
It's not straightforward for everything, and there's lots of different routes to getting different things.
yes, right. So you wouldn't want to be the government sorting this out, really. But maybe we could start with that, really, because we were chatting beforehand a bit about the strategy or lack of.
Yes.
Because we don't think there's been an official cancer strategy since 2015 or so.
Yeah,
Right? It
absolutely.
was mentioned in the long-term plan, but
Yeah.
it was just a couple of targets, really, about screening and waiting times.
Yeah.
So do you think that it's going to be more up to, say, other stakeholders like the cancer alliances to take this forward and make this happen?
Well, I think it could be up for debate, actually.
Yeah.
It's really interesting how, there hasn't been an update for 4 years, and even in light of, the long-term plan, we still haven't got an update. It's kind of based on 5-year forward view.
Yeah.
So I think there is a need there nationally to
Yeah.
look at that strategy, and you've got the Cancer Vanguard, which I would argue could be the main stakeholder to deliver that strategy,
Yeah.
because actually the alliances are really there to look at, to plan and deliver it locally within that footprint. So,
Right.
otherwise we're going to get 16 variations of a strategy. Developing a strategy, it does need to be done by a national body.
Yeah, right.
Yeah.
So we think that at the moment there's fewer cancer alliances than there will be. Eventually they're going to map on to the integrated care systems.
Yeah.
And we think there's going to be about 40 of them or so. So we're looking at about 40 cancer alliances.
Yeah.
And my understanding is
Yeah.
there's going to be representation on the boards of each ICS
Yes.
from a cancer alliance, and that would be basically the cancer wing.
Yeah.
Oh, yeah, okay. So we think that's going to be the key customer in the future. But it's complicated, isn't it? Because there's different parts of the pathway. Again, we're falling into this, cancer's owned by this or that. But
Yeah.
there's screening,
Yes.
there's diagnosis, there's chemotherapy, there's
Yeah.
radiotherapy, there's surgery,
Yes.
and then there's rehabilitation.
Yes.
So what's your understanding about the ownership here and how that's going to break down, right?
Yeah, I think it is interesting, and I think you've got different parts of the system being incentivised by different things. So
Yeah.
it isn't easy just to say, like you said, this is one strategy and we're all following it. It's everything's through specialised commissioning,
Yeah.
or everything's through NHS England normal commissioning. It's not. It's
Yeah.
quite fragmented.
Yes.
I think it will really help once we get to that stage where you've got cancer alliances aligned to ICSs.
Yeah.
That makes sense in terms of integrated care, in terms of then the providers within that, the cancer providers forming it'd be interesting in whether they align with the
Yeah.
ICPs, integrated care part providers,
Yeah.
to deliver cancer services in
Yes.
all of those localities.
Yeah.
It'll be really interesting where all the rapid diagnostic centres are going to be put, for instance.
Yes.
Are they going to put them footprint-wise, align everything? It would make everything so much simpler
Yeah.
if they do, but we have yet to see where they're going to be placed.
Yeah, well, let's stick with rapid diagnostic centres for a minute, because we think they're really important, right?
Yeah.
So a lot of these new medicines that are coming out depend fundamentally on these diagnostic centres and the way they're going to find patients that these new medicines will work on. Yeah. So if that's not in place, then this whole generation of incredible medicines are just sitting there.
Exactly.
Really.
And have got funding.
Yeah.
You know, so they've got funding either
through the system, through
CDF or NICE, or they've even got a NICE appraisal. Yet to access the medicine, you've got to have the companion diagnostic to go with it to identify that that patient's eligible for that medicine, and it's going to work. You know, there's no point just saying, oh well, we just won't do the companion diagnostics and we'll just open up the floodgates for a particular NICE medication, or we'll just use it in all breast cancer patients. That's not going to work, because these medicines are very specific. It's precision medicine. Targeted. Yeah. So they work extremely well in their targeted population. But they're not like chemotherapy. They're not for the masses, and it'll only work on 40%. It'll work on the 10% and give you 90% coverage and work very well. So it is really important for patients. I mean, the issues around them are many, these diagnostic centres. So they bring together lots of different specialties and multidisciplinary, aren't they? So they are.
Informatics and
Absolutely.
Diagnostics.
And really quite sophisticated laboratory expertise, actually. And being able to, you know, take the test on the biopsy or the genetic material and get it to the lab and test it in a quick time is really important.
There's 10 at the moment, as I understand.
There's 10 at the moment.
And when do we have to have full coverage by? Is it a couple of years?
Yeah, I think is it 2023?
23.
I think it's 23.
Let's say that. So they've got a lot of work to do, and I'd imagine the Cancer Alliances would be owning this.
Absolutely. And it goes in line with the genomic kind of increase in testing. So they're wanting everywhere to improve their genomic testing. Yeah. And by 2023 to have 100,000 patients tested genomically, which again is really important, because that's, it's not just companion diagnostics. A big element of that is genetic testing. Right.
So how do we get the patients into the system then? Is that the role of primary care and perhaps primary care networks?
Yes.
You haven't really mentioned yet.
Yeah, absolutely. So they're the new organised, place-based organisation that's come out of the long-term plan. Yeah. And one of their workstream deliverables is to actually improve the early diagnosis of cancer. Right. It's not for a few years, 2023, 24, but actually, these are a new organisation. They've got lots of other work streams, but it'll be really interesting to find out how are they going to be able to do this, because obviously they're looking after the GPs. How do you get all the GPs really understanding, is there a training element to this? Quite a large training element out in primary care. Yes. We know about the workforce issues. Hopefully we're going to be getting more GPs in, but these are new GPs. How do we get them up to the expertise of being able to identify this patient might have cancer and get them into the right service quickly?
And what about variation? Because that's probably going to happen, isn't it? So somewhere in Manchester, you're going to be more likely to have a better service in that respect than Cumbria.
Yeah, exactly. And I think, if you are living around one of the centres of excellence, one of the vanguard sites.
Clatterbridge.
Yeah, the Christie, the Royal Brompton. You are much likely to get access to international experts. They are your local consultant. Yeah. And therefore, but you get access to clinical trials much easier. And, if you're in Cumbria and you get sent to Carlisle, or, it's not quite the same kind of system.
We've been noticing with our work on some of the prescribing data, there's a lot of variation in medicines. Yeah. So that needs to be smoothed out as well, doesn't it? Right.
Well, I think it's trying to understand what's driving that. Is it actually some places have a service and some places don't, but there's clear referral guidelines into the centres locally that do have a service. Yeah. So therefore you would have some hospital trusts that aren't using any medicines because they don't have a service, which is fair enough. But is there being blocks put in the system? We all know that if you get a NICE technology appraisal, then that has to be made available within 3 months.
Yeah.
But made available is actually just putting on formulary when actually access to patients is protocols.
Yeah.
So, you know, there could be various barriers being put up, either
Yes.
commissioning or in delivery or in access, that
Yeah.
probably is that data can
And that
help you
could come
understand.
down to local politics
Yes.
or finance
Yes.
or the way the system has evolved.
Yes,
Yeah.
to set up delivery, you know, it might be
Yeah.
unintentional,
So
but
there's no easy way around it.
not really.
Okay, so we've covered quite a lot already. I'm just maybe thinking, how can we enable industry to be part of the solution here? What can they do? Or is it just a matter that they have to just wait and see what will happen and let events take their course? Or is there an education thing that they can do?
I think really one of the big things is that, you know, they've really got to understand integrated care systems and the new place-based care delivery model.
Yeah,
Now, you know, cancer is complicated because you've got a lot of services that are directly commissioned through specialised commissioning.
yeah,
But the fact that, like you've said, there's a mood to actually align the cancer alliances with ICSs
yeah,
and to have board members on each respectively, then there is going to be more joined up thinking. So, and I think the one big thing as well is that, you know, companies need to not just talk about their medicine and even just and their companion diagnostic, but think of the whole pathway. You know, how do they help and support the breast cancer pathway, for instance, from screening, you know, through diagnosis into treatment and access, and then out the other side in supporting patients longer term. You know, they're the conversations people are wanting to have at a high level to then bring partners in to look at delivering that. Now, that might be through technology. You know, there's a big part to play in technology and especially supporting patients. So I think there's a lot pharma can do,
yeah,
but it's thinking very much in the language and speak the language of the NHS now.
right,
You know, and I think cancer will be a big test bed for this
yeah,
because traditionally it's been very organisationally led
yes.
and delivered.
So I suspect they're beginning to get better at talking amongst themselves, for example with diagnostics companies, about how they can put together a package that covers all of that, but that has to be mirrored in how they work with the NHS. Right?
Yes,
The
absolutely.
multitude of stakeholders you've got.
Yeah, absolutely, and at a higher level, and you know, it's the how. It's always the how. It's not necessarily what and why.
Yeah.
It's how are they going to do things, and I think that's where pharma can play a big role.
Okay, that's great. I think we've covered a lot. It feels like we could say a lot more, but we try and keep these things short and pithy. And maybe you'll join me for another one at some point?
Maybe.
Excellent. Okay, well, that's all we've got time for today, but thanks very much. That was a Wilmington Healthcare Coffee conversation. Bye-bye.